Epidemiology of acute kidney injury in critically ill children and young adults. Definition: acute kidney injury is a sudden episode of kidney failure or kidney damage that happens within a few hours or a few days. AKI causes a build-up of wasted products in your blood and makes it hard for your kidneys to keep the right balance of fluid in your body.
Renal failure, which is defined as a decrease in glomerular filtration rate. And I put reversible because in quotations because it may be reversible. But essentially, it's damage to the kidneys, which will cause a few problems, many problems actually. And so we'll look at these problems and some causes of acute renal failure. So here I'm just drawing the anatomy. Here we have the kidneys, the inferior vena cava, where the renal veins drain into. And then we have the ribs here. And here
Applications: maintenance of volume homeostasis and correction of biochemical anomalies remain the primary goals of treatments, and may include the following measures: correction of fluid overload with furosemide, correction of severe acidosis with bicarbonate administration, which can be important as a bridge to dialysis, correction of hyperkalemia, correction of hematologic abnormalities with measures such as transfusions and administration of desmopressin or estrogen.
About is that the heart pumps blood to the kidney makes urine that goes to the bladder, and then of course it's excreted. So the three organs that we're going to deal with acute kidney injury are heart, kidney, and everything after kidney, which I'll just call bladder. Okay, so the way that this is broken down is that there are three causes of acute kidney injury: pre-renal, everything before the kidney, which we're going to really focus on the heart; intrinsic, which is everything within the kidney itself; and then post-renal, everything after the kidney, which we're going to refer to as bladder. Think about as a bladder. So again, pre-renal, intrinsic, post-renal. Everything before the kidney, heart. Everything inside the kidney, intrinsic. Everything post-renal or after the kidney, bladder. So let's talk about pre-renal first. What are the causes of pre-renal acute kidney injury? Well, we could knock out the heart. So it could be a cardiogenic cause. If you have a massive MI, well, you're going to have a pre-renal kidney injury because the heart can no longer pump blood to the kidney. And as you can see here, I've illustrated that by just removing the blood from the afferent circulation to the kidney. In addition, we could have any number of hypovolemia. Hypovolemia, shown here as just a decreased flow to the kidney, can be from a few things. You want to remember the 3 Ds: diuresis, diarrhea, and dehydration. Any one of those three things are going to cause you to be hypovolemic. If you're diuresing too much, you're going to have low volume. If you're diarrheaing, if that's a word, too much, you're going to have hypovolemia. And if you're dehydrated, you're going to have hypovolemia. So anything that causes a decreased effective circulating volume is going to cause pre-renal azotemia, or pre-renal kidney injury. The next thing I want to talk about is the intrinsic causes of acute kidney injury. What in the kidney itself? So, like from a global standpoint, we could have a glomerulonephritis where we just knock out the kidney, okay? Glomerulonephritis. There are many causes of glomerulonephritis. You can see a kidney pathology lecture to be able to better differentiate between them. But just as a class, as a whole, when you think of glomerulonephritis, you're going to think of acute kidney injury that's intrinsic. Additionally, you could have a renal tubular acidosis. You're still knocking out the kidney, but what's happening here is that you have one of two causes. One can be ischemic. Ischemic kind of ties back to pre-renal. We have a decreased blood supply and the kidney gets knocked out because it no longer can nourish itself. Additionally, you can have toxic
Pros and cons. Patients with severe AKI had significantly higher mortality than those without severe AKI. Mortality was higher in patients with low urine output than in those with normal output. Renal replacement therapy was required in 1.5% of patients. It reduced comfort and increased risk for death. Acute kidney injury is associated with adverse outcomes in critically ill adults in a prospective multinational study. Research examined the association between AKI and mortality and 28 days in 4,683 critical ill children and young adults admitted to 32 pediatric critical care units. AKI was considered severe if the serum creatinine level increased to at least twice baseline. Statistics: a total of 4,683 patients were evaluated acute kidney injury developed in 1,261 patients, and severe acute kidney injury developed in 543 patients. Severe acute kidney injury conferring an increased risk of death by day 28 after adjustment for 16 covariates. Death occurred in 60 of the 543 patients with severe acute kidney injury versus 105 of the 4,140 patients without severe acute kidney injury. Severe acute kidney injury was associated with increase of mechanical ventilation and renal replacement therapy. A stepwise increase in 28-day mortality was associated with worsening severity of acute kidney injury. Assessment of acute kidney injury according to the plasma creatinine level alone failed to identify acute kidney injury in 65.2% of patients with low urine output. Conclusion: acute kidney injury is common and its association with poor outcomes, including increased mortality among critically ill children and young adults.